As you can see, you can have many patients who attend the clinic complaining of oral ulceration. Different presentations, as you can see. So, oral ulceration is the lesion ulcer. Patients are having lesions called ulcers, and ulcers are as a result of loss of part of the tissue or part of the oral mucosa. Uh, when it is affecting the whole thickness of the epithelium and usually part of the connective tissue, it is called an ulcer. So loss of the epithelium, and the base will be the underlying connective tissue. When there is just loss of part of the epithelium, it is called erosion. So erosion is superficial loss of the tissue. So it is not deep when it is erosion is a deeper lesion. But some ulcers you can see in the lower right picture with the presentation of diffuse oral ulceration causing significant symptoms to the patient. So these ulcers, the features of these ulcers should be taken into consideration in the differential diagnosis. So oral ulceration is that topic talking about patients who present to your clinic having single or multiple oral ulcers. You have to know this classification of oral ulcers in order to make a correct diagnosis. You should know that ulcers can be the result of infections. We already discussed last meeting in the last webinar that some viruses and some bacteria and some fungi can cause oral ulcers. If you remember, for example, herpes simplex virus. If you remember the TB, syphilis. If you remember the deep mycosis, fungal infection, presents as an oral ulcers. Also, ulcers can be as a result of trauma, whether this trauma is mechanical trauma, physical trauma, or chemicals, or for example, thermal, or it could be sometimes radiation. So it could be traumatic ulcers. And sometimes the ulcers are not the only thing that the patient is having. Sometimes these patients may present with ulcers as a result or secondary to systematic disease, for example, hematologic deficiencies, iron deficiency anemia, or other deficiencies can cause oral ulcers. GIT disorders like, for example, ulcerative colitis or other inflammatory bowel diseases can cause also or associated with oral ulcers. Bahjat disease, as we can see in the future, HIV disease can be associated, as we discussed the last time, with ulcers. Ulcers could be associated with dermatological diseases, sometimes as part of a disease that affects the skin. of the similarity between the skin and mucous membranes, and these ulcers can also be present in the oral cavity, for example, lichen planus, the one we mentioned before, lichen planus associated with oral ulcers, lupus as well. And we will discuss also a group of diseases called vesiculobullous disorders. These vesiculobullous disorders are inflammatory or immune mediated mostly diseases that cause the appearance of vesicles with subsequent rupture of these vesicles or pulli, and it will end with oral ulcers. So these are called vesiculobullous diseases. And more significantly, sometimes the oral ulcers could be neoplastic. So they could be a cancer. Like, for example, if you remember, squamous cell carcinoma can present as oral ulcer, or sometimes other malignancies other than squamous cell carcinoma, malignancies of the connective tissue or the epithelium, other than and present with ulcers, or sometimes metastatic tumors from other areas of the body to the oral cavity also can present with ulcers. Sometimes we think about all these possible causes of oral ulcers, and we do not reach a diagnosis, and we do not find a cause for the oral ulcers. The ulcers without known cause are called recurrent aphthous stomatitis or recurrent aphthous ulcers. So these are idiopathic, without known cause ulcers that present in a significant number of patients without known cause, as you can see, as we will discuss, called recurrent aphthous stomatitis or aphthous ulcers. How many of you are attending? Just 5? Okay. This will raise a significant. Okay. So just 5 are listening. Disappointed.
لا دكتور أكثر من 5.
دكتور في 95 في الاجتماع.
Are you sure? Yeah, 94.
Oh, دكتور.
95. Over 5 is the number of 5 here. Yes, 95 updated. Okay. Any questions so far? Annie? Annie, are you listening to us?
Yes.
Anything?
No, all good. Thank you.
Okay. Okay, start with the traumatic ulcers. As we said, ulcers can be the result of infections. We already discussed the infections the last time, and ulcers also can be the result of trauma. Trauma could be mechanical. Mechanical trauma could be by, for example, trauma by restorations or broken teeth, broken restorations, by roughness of calculus, for example, trauma by teeth during biting, whatever the cause. So these can be the result or the causes of all things can be causing or causative agent of oral ulcerations. How to, as you can see here, for example, this patient is having like restoration with a broken from the lingual side, and it is causing ulcers to the border of the tongue. So he has rough surface. This also, the first patient is having like sharp teeth and is causing ulcer at the lateral border of the tongue. How to confirm the diagnosis? You have to find the cause that fit with the site of the ulcer, and also the shape of the ulcer. So you have to find an adjacent cause. With oral ulcers, you have to find like a cause of trauma adjacent to this ulcer. The first thing to do. So you have to find the cause, and this cause should fit with the size and shape of the ulcer. And you have to exclude or remove this cause. If you correct for example, the restoration, you do another restoration. This ulcer should heal within 2 weeks. If the ulcer after 2 weeks persisted in the same site, no healing, this means that it is not the result of this cause. So you have to think about something else. You have to take a biopsy. In any ulcer, you do not find the cause, and if this cause or removal of this cause did not correct the or resulted in healing of the ulcer, you have to take a biopsy. In the case of the traumatic ulcers, as you can see in the biopsy, you will find just non-specific ulcer. It is just loss of part of the epithelium, as you can see here. At both edges of the image, there is epithelium. In the center, there is no epithelium. So it is an ulcer. And in the base of the ulcer, you can see granulation tissue, inflammation, fibrin deposition on the surface, but nothing specific. So it is just a non-specific oral ulcer. So you don't find anything, just loss of the epithelium, inflammation. So these are features of traumatic ulcers. They are non-specific ulcers, just loss of the epithelium and inflammation of the underlying base. Sometimes if the cause of the ulcer was chronic, you can see that the ulcer, at the periphery of the ulcer, you will find like whitish areas, because if you remember, mild chronic irritation will result in hyperplasia and hyperkeratosis to the epithelium. So in the center where the trauma is significant, it will cause loss of the tissue, causing ulcer. But at the periphery, the trauma is less intense, so it will cause hyperkeratosis and hyperplasia. So in chronic ulcers, as these you are seeing now, they are characterized by periphery, a whitish periphery, and fibrosis. So it will be like firm ulcer at the periphery, chronic for a long time. So sometimes chronic traumatic ulcers can be mixed with malignant ulcers. So you have to be careful. You have to remove the cause and do follow up. These ulcers, because they are the result of trauma, there will be healing. But if it is a malignant ulcer, it will not heal. Another examples of traumatic ulcers, as you can see, for example, upper left, from rotary instruments, from during drilling of teeth. Sometimes by mistake you will cause oral ulcer. So this is traumatic ulcer by rotary instruments. Polishing disc during polishing of teeth, and after scaling you will do sometimes polishing to remove the stains from the teeth. So it will the polishing disc can cause sometimes trauma to the gingiva. Also, lower left, you can see ulcer as a result of cotton roll. Sometimes if you put a cotton roll to isolate the teeth during restoration, the patient is anxious and there is stress. So there will be like a dryness of the oral cavity, dry mouth. If you, after the finishing the restoration, you remove the cotton roll quickly, it will cause sometimes loss of the tissue. So you have to be careful during removal of the cotton rolls after finishing restorations. And some patients who are having dryness because of the stress, fear of the situation, it will result in ulceration. So you have to do wetting, put water on the cotton roll and then remove the cotton roll. Saliva ejector, sometimes also saliva ejector can stuck to the floor of the mouth to soft tissue. It can cause sometimes during removal oral ulceration. Sometimes by dentures, as you can see here for patient, a dangerous patient. Dentulous patient, particularly in the lower denture, because of resorption with time of the alveolar ridge of the bone. So there will be the flanges of the denture will be overextended, and they will gradually cause trauma to the depth of the sulcus. So patients who are having old dentures sometimes present to your clinic by ulcers at the periphery of the denture because of the resorption of the alveolar ridge. Here, sometimes ulcers can result after anesthesia, block anesthesia. If you do block anesthesia to patients in the to do restorations in the mandible and the lower teeth, sometimes, particularly in young patients, after you finish the procedure, and the patient will have anesthesia of the lower lip, so they don't feel anything in the lower lip, and sometimes they do trauma to their lower lip because they have no other sensation. So sometimes after anesthesia, the patient will come to you in the next visit with ulceration to the lower lip or the tongues, for example. Also, sometimes the patients who have orthodontic appliances, sometimes they do like sucking of the buccal mucosa or the labial mucosa against the appliance. And this will cause irritation to the labial mucosa or the buccal mucosa and may result in ulceration. Also, excessive tooth brushing. Sometimes patients, because of they have a fear of poor oral hygiene, so they try to do excessive tooth brushing, and this will cause anxiety or depression. They can bite on their tongue or lip, and they induce that themselves. Boost the ulcers by themselves. So we call these are factitious ulcers by biting or by their nails. Chemicals also can be used in the oral cavity and cause oral ulceration. For example, the aspirin burn, a common example, famous example, that patients they have toothache, and they think that if they put the aspirin tablet adjacent to the tooth, it will be more effective. So they put the aspirin tablet in the buccal vestibule or labial vestibule adjacent to the painful tooth. And if you remember that aspirin is an acid, salicylic acid, so it will dissolve, causing acid will cause irritation to the oral epithelium, necrosis to the oral epithelium with subsequent erosion or ulcers. Chemicals also, we use a lot of chemicals in dentistry. Some of these chemicals are acidic, and they can cause also ulceration. So we have to be careful during use of these chemicals, bleaching agents, or some chemicals used in bleaching, in endodontic treatment, and others. Also, thermal things can cause oral ulcers, as expected. If you eat something very hot, it will cause oral ulcer, particularly in the palate. Sometimes after eating something very hot. A common example, they call it pizza burn. It will be like redness and erythema in the palate. As in the first example, or cheese, for example, or whatever material that is or food taken in a hot condition. Impression materials, used to use also some impression materials, and these impression materials sometimes they are hot and may cause particularly in prosthetic dentistry, and they may cause oral ulceration. Radiation-induced oral ulcers are patients who are treated with radiotherapy. After intake of radiotherapy for the treatment of, for example, oral malignancy, the radiation will cause endarteritis obliterans, obliteration of the blood vessels. So the area will be in an ischemic condition. No enough blood is reaching the area because of the obliteration of the blood vessels. And this will cause subsequent erosion and ulceration in the area. This can be secondary to oral radiation. After a while, I mean. In patients who are having radiotherapy, the ulcers can present initially after the radiotherapy, and later on after a while because of the endarteritis obliterans. And sometimes it will be mixed with the recurrency of this tumor. So you have to take into account that after radiotherapy, sometimes an ulcer will appear in the future because of endarteritis obliterans. So it can be sometimes, as I said, mixed with recurrence of the tumor. So you have to take a biopsy. Xenophilic ulcers, it is a kind of chronic ulcers, traumatic ulcers. They connect with the crush injuries to the tongue particularly. So the patient present with a chronic ulcer without known cause, but there is usually a history of chronic crushing trauma to the tongue. And you can see in the histopathology that it is these are kind of ulcers. They have a lot of xenophilic cells, the eosinophils, and these present within the base of the ulcers, and they can help in the diagnosis. Eosinophilic, they call it eosinophilic ulcer. So it is a chronic type of a special type of chronic ulcers where there is a lot of eosinophils in the tissue, and they think that it is the result of a crushing trauma. The most famous of the ulcers are the recurrent stomatitis, and as we said, it is idiopathic without known cause. It is one of the most common ulcerations that affect up to 10 to 25% of the population. So you have to know the recurrent ulcers. It's a very common ulcer. Maybe up to 1/3 of you as students may have recurrent stomatitis or recurrent ulcer, ulcers they call it. in a study we conducted before, 37.1% of the students, they have 1 year history of aphthous ulcer. In the last year, I mean, they got aphthous ulcers. At the time of examination, 5.1% they have this ulceration. So the others are just with the history of all ulcers, but 5% of them, they have at the time of examination the ulcers. The onset, it is usually the aphthous ulcers they present in the first 3 decades of life. So the usual presentation is in young patients less than 30, and it can be in males and females. Usually the patients are non-smokers. And we will see the connection between the aphthous and the smoking. The patients present with prodromal symptoms before the ulcers. They feel like there is tingling sensation, burning sensation at the site of the ulcer, and then there will be the appearance of the ulcer. Clinical symptoms, the presentation will be like an ulcer associated with pain. It is very painful. These types of ulcers, they are characterized by pain, so they are painful ulcers during the presence of this ulcer. But the ulcer is present for usually for 1 week to 2 weeks, and it will heal by itself. So there will be disappearance of the pain. But also the other symptoms include sometimes the patients are having difficulty with the eating because of the pain, and during intake of food, it may increase the severity of the pain because of, for example, whatever stimulants or spices in the food. So it will increase the pain. To diagnosis of aphthous ulcers, the diagnosis is a clinical diagnosis. Usually there is no need to take a biopsy. It is just the clinical appearance, and the history can help in the diagnosis. So they are straightforward, very easy to diagnose. Once you see the shape of the ulcer and the size and the color, and it is painful, and they are multiple sometimes. So these are characteristic features. They can help in the diagnosis. You no need to take a biopsy. If you take a biopsy, it is just a non-specific ulcer, same as the traumatic ulcer, as you can see here in the tissue. We have many forms. We have 3 forms of the aphthous ulcers: minor, major, and herpetoform. You have to read about these 3 types. The most common type, which represent 80% of the cases, is the minor aphthous ulcer. Minor because of the symptoms and because of the size of the ulcer, less than 1 centimeter, and the duration usually like 1 week, 10 days, and there will be a healing. So these are the minor aphthous ulcers, and they can be 1 or they can be multiple, appear at the same time, 1 to 6 ulcers. And they can affect any site, but mostly they affect the non-keratinized parts of the oral mucosa. The minor aphthous ulcers, they affect the non-keratinized part of the oral mucosa. You can see them mostly on the labial mucosa, buccal mucosa, floor of the mouth, ventral surface of the tongue. So the non-keratinized part of the oral mucosa. The shape is round, as you can see, and they are grayish whitish color, and surrounded by red margin. This is very important to reach the diagnosis. So it is whitish surrounded by red margin because of the inflammation, vascularity in the tissue. So you will see the margin of the ulcer as red. As you can see here, there are multiple in some patients. The duration, as we said, 1 week, 10 days, there will be healing. No scarring. There will the healing will not be followed by scarring. So because they are superficial, not that deep, they will not cause scarring. Recurrence rate variable. In some patients, recurrence every month. In some patients, every 2-3 months. In some or in other patients, every 6 months. So the recurrence rate is variable between patients. But the important thing here is that they are recurrent ulcers. They are characterized by recurrence. It is not just one times as the, for example, if you remember the recurrent, ulcers associated with the herpes virus, herpetic gingivostomatitis, that it comes as one time. But here the ulcers, they are recurrent. So this is important in the history. The major after ulcers, they are presenting more symptoms and are like they need longer time to heal, and they are followed by scarring. So you can see at the site of the healing of the ulcer, scarring. As you can see in this patient, scarring in a previous ulcer. The third type is the herpetiform aphthous ulcer. It is called so herpetiform because it resembles the ulcers caused by herpes virus. If you remember the herpes viruses, they cause multiple ulcers, and we said that they are irregular ulcers and they are whitish surrounded by red margin, multiple, could be hundreds sometimes. So these are called herpetiform aphthous ulcers. You have here to differentiate between this type of aphthous ulcers and the herpes infection. You have to find what are the differences between herpetiform aphthous ulcers and herpetic gingivostomatitis. If you remember the herpetic gingivostomatitis, is it recurrent or not? The patient in herpetiform aphthous ulcers, are they having systemic signs and symptoms like in herpetic infections, fever, malaise, lymphadenopathy? Is it associated with gingivitis here, similar to the herpetiform, similar to herpetic gingivostomatitis? If you remember herpetic gingivostomatitis, there was widespread gingivitis. Is it present here? So many things you have to think about to differentiate between the herpetiform aphthous ulcer and herpetic gingivostomatitis. The ulcers, if you remember, we said they are idiopathic without known cause, but they incriminate all these factors. If you can see, many factors are incriminated as a cause of aphthous ulcers, but as the name implies, they are without definite cause yet, so they are not sure what is the cause of the aphthous ulcers. They found it sometimes associated with local factors. For example, if the patient causes trauma to the buccal mucosa or labial mucosa. It is followed by aphthous ulcer. So it is like the trauma is the initiating factor to the ulcer. It determines the site, but it is not the cause. So they are not sure what is the cause of the aphthous ulcers. They incriminated certain microorganisms like H. pylori, streptococci, and others. In some patients, they associated with hereditary factors. 40% of the patients with aphthous ulcers, they have family history, positive family history, but 60% they have no family history. Psychological factors, they associated with stress. They say that aphthous ulcer increases at the time of examination of the students, for example, because of stress. But the mechanism is not clear why stress is causing aphthous ulcers. In some patients who they think that they are a result of allergy to chocolate, coffee, certain nuts, and others. Hormonal factors. Some women, they connect the ulcers with the menstrual cycle and something like that, or for example, puberty or whatever, but it is not clear what is the relation. Tobacco, they say that aphthous ulcer is less common in smokers. This possibly because of the that smoking it causes irritation to the oral mucosa, thermal, chemical, so it will cause hyperplasia and hyperkeratosis to the oral epithelium. So it will be more resistant to ulceration. This is what they say as the mechanism. So aphthous ulcers generally they are less common in smokers compared with non-smokers. But this shouldn't be taken as an advantage of smoking, because if you remember, smoking is causing hundreds of diseases in the body, and some of these are malignant tumors. So you have to think about the thing as a whole. Systemic diseases, they are connected, as we said, the aphthous ulcers with certain systemic diseases like Crohn's disease or Behcet or HIV or other GIT disorders. But and vast majority of the patients, they have no systemic diseases. Nutritional deficiency, patients with deficiency of iron, folate, or B12, for example, they have aphthous, they call it aphthous-like ulcers. They present with aphthous-like ulcers, and once you correct the deficiency, the ulcers will disappear. So as a routine, usually what we do in our clinics, once we have patients with aphthous ulcers, we do like routine checkup. We ask for CBC, serum, ferritin, folate, B12 to exclude the deficiency of any of these factors. If we find the deficiency, we will prescribe certain, after doing investigations with our colleagues in the internists, who will check what is the reason for the deficiency of iron or folate or B12, and correction of the deficiency, as we said, will help in decreasing the severity or sometimes disappearance of the ulcers. The pathogenesis of aphthous ulcers, they are immune mediated, so you will read about what is the pathogenesis. It is cell-mediated damage or to the oral epithelium. The CD8 cells, T cells, they will attack the oral epithelium and cause damage to the oral epithelium, ulceration. But why they are doing so, nobody knows. It's unknown. In Behçet disease, they are patients presenting with aphthous like ulcers in the oral cavity, but they have other things. They have other things. They have inflamed eyes. They have genital ulcers similar to the aphthous ulcers. They have arthritis, joint pain. They have skin lesions. So there are multiple things happening with each other. These are called, or these are described by ophthalmologists called Behçet, Turkish. And they call this association of symptoms and signs Behçet disease. The main things in Behçet disease, the major criteria, they are oral ulcers, similar to the recurrent aphthous ulcers, but you will find a few things that are different. And for example, the shape, the location of the ulcers. And the patients of the major criteria also, they have eye lesions, they have inflammations of the eye, whether uveitis, conjunctivitis, or retinitis, and they have genital ulcers similar to the aphthous ulcers in the oral cavity. They have skin lesions like papulopustular eruptions, like pustules in the skin, as you can see in this example. And they have also sometimes erythema nodosum, like elevated red lesions, and sometimes they have thrombophlebitis in the skin. So these are the skin lesions present in patients with Behçet disease. And also they are positive to what's called the pathergy test. If they do needle stick to the skin or in the oral cavity by sharp thing, after a while an ulcer will develop in the oral cavity. So this is called positive pathergy test. It is positive in patient with Behçet disease. Or in the skin, it will cause here, as you can see, like an ulcer in the skin. Minor criteria, also the patients will have arthralgia, they have CNS lesions, central nervous system lesions. They will have thrombotic vascular lesions, they have GIT lesions, for example, ulcers. So the combination of these major minor criteria is called Behçet disease. Vesicular loss disorders, these are diseases causing vesicles or pulli in the oral cavity, followed by rupture and ulceration. We can have many of them. Some of them are developing in the inside the epithelium. So they are superficial vesicles or pulli. The common example is pemphigus. And we have also inside the epithelium other things other than the pemphigus. Pemphigus is in the category they called acantholytic lesions, where there is loss of the attachment between the epithelial cells. So vesicle will develop in the epithelium, and then rupture will cause ulcers. Another example of acantholytic intraepithelial vesicle or pulli is the follicular keratosis we mentioned in the white lesions. And also we have non-acantholytic damage to the epithelial cells themselves, not the attachment between the epithelial cells. If you remember the herpes simplex virus, for example, the viral infections, they cause rupture of the epithelial cells and they cause vesicles inside the epithelium, and then rupture will cause ulceration. And we have vesiculobullous disorders that cause vesicles and bully developing below the epithelium, not in the epithelium. So there is separation of the epithelium from the underlying tissue with subsequent filling with the fluid. So it is called subepithelial vesicles or bully. And we have a list of diseases that cause subepithelial vesicles or bully, like bullous lichen planus, erythema multiforme, and other vesiculobullous disorders. Exam intraepithelial. It is an autoimmune disease where there are antigens connecting the epithelial cells with each other. So there will be vesicles, as you can see, inside the epithelial cells. So it is superficial. It will cause rupture and oral and cause ulcerations. So it is damage to the factors or the attachment between the epithelial cells. Clinically, it can affect patients who are usually females, middle to elderly age in certain regions. It is uncommon, but you can see some examples who will attend your clinic because of pemphigus. The oral lesions are 50% of the patient initial site. They develop in the oral cavity, but ultimately all the patients will have skin lesions. So it can present in the oral cavity, but it will affect the skin. In very significant, in very minor patients or percentage of patients, it is confined to the oral cavity, just confined to the oral cavity. It is so they will rupture, causing a significant damage to the can see, and can affect other sites like nasopharynx, esophagus, vagina, whatever other areas, and can be fatal because it will cause infections, loss of fluid, proteins, so and the patient will be susceptible to infections to the skin and other affected areas before the use of systemic steroids. And Kuruski sky sign, where you press on the tissue and cause lateral friction, it will result in development of vesicles or bully in these patients. So this is called Kuruski sign. It is positive in these patients. It is intraepithelial, so the separation is within the epithelium. So it is intraepithelial vesicle or bully. And you can see that the basal cells, they remain attached to the basement membrane. So the separation is suprabasal in the suprabasal region, and you can see that the cells, they lost their attachment to each other, so they become round and shrunken. They are called Zang cells. They can be seen within the fluid, within the vesicles. And the basal cells attached to the basement membrane, they remain attached to the basement membrane, and they are called the tombstones, as you can see here. To confirm the diagnosis, you have to do direct immunofluorescence. You will find what's called fishnet appearance. It is positive fishnet appearance, deposition of the fluorescein dye between the epithelial cells, because this is the site of the antibodies. It is attacking the desmosomes between the epithelial cells. Other minor types, it's called pemphigus foliaceus. It is more superficial, and we have another rare type, vegetans, where after the rupture there will be eruption of like vegetations. And we have another also minor type. It is called paraneoplastic pemphigus. It is associated with internal malignancies. Pemphigoid, you have to compare the pemphigoid to pemphigus. The separation here is subepithelial, and you will find the direct immunofluorescent at the basement membrane zone, because this is the area of deposition of the autoantibodies at the basement membrane zone. IgG and C3, they are deposited in the basement membrane sites, and will cause separation below the epithelium. So the full thickness of the epithelium will be above to rupture. So in these patients, you can see in some patients the bully or vesicles, and because they are subepithelial, they are sometimes filled with blood. So you can see them clinically having blood, as you can see here, because they are subepithelial, where there is rupture of the blood vessels. The severity is less than the severity of pemphigus, the pemphigoid, and we have two types of pemphigoid. We have the bullous pemphigoid affect mainly the skin, and we have the mucous membrane pemphigoid that affect the mucous membranes and the skin, but mainly the mucous membranes. Skin is minimally affected. Our mucosa will have like these vesicles. They are filled with blood, and they have longer duration, and they are more deeper. So they are hemorrhagic. They are containing blood compared with the pemphigus. But when they rupture, they will cause widespread erosions, as you can see here. And because they will be followed by scarring. Sometimes the pemphigoid is mainly affecting just the gingiva, minor types. It is called squamative gingivitis. And because it's a mucous membrane pemphigoid, it will affect other mucous membranes like the conjunctiva, the nasopharynx, the larynx, the esophagus, and the genital areas. Sometimes will cause complications in the eyes and may lead to blindness. Erythema multiforme is another vesicular blood loss disorders, but here the pathogenesis is slightly different. They are saying that it is like a reaction to certain antigens causing antibody complexes that are deposited in the blood vessels and causing ulceration. They are mainly affecting young adults, so mainly males, but pemphigoid mainly affect females. And we have mild forms and severe forms. In the mild form, you will find the skin lesions in the form of target lesions, as you can see here, important for the erythema multiforme. And we have the oral lesions. They are non-specific, causing widespread erosions. And the patient also will have circumoral crusting. And this circumoral crusting, as you remember, we saw it also in cases of herpetic gingivostomatitis. Severe forms, it's called Stevens-Johnson syndrome, more severe erosions and ulcerations in these patients. Pathogenesis, as we said, antigen antibody complexes, type 3 hypersensitivity, either to herpes virus, so it is following herpetic secondary herpes like herpes labialis, or sometimes because of certain drug or sometimes of drugs. And we have less common disease like dermatitis herpetiformis. You have to see because mainly affecting the skin, and they are resembling herpetiform ulcers. It is immune mediated. And associated with gluten hypersensitivity. Oral lesions, they are non-specific in 70% of the cases, and they are as a result of deposition of IgG and C3 at the tip of the connective tissue papillae and the dermatitis herpetiformis. So if you do to confirm the diagnosis, you need direct immunofluorescence. Linear IgA disease, similar to dermatitis herpetiformis, but here the deposition is by IgA at the basement membrane zone, and not associated with the gluten hypersensitivity. The last thing is the epidermolysis bullosa. It is we have many types of these epidermolysis bullosa, up to 30 types. They are variable in severity. They present early in life, and they can be fatal. They causing in some patients severe erosions and like ulcerations and scarring. Even in the oral cavity, any trauma will result in scarring. Limitation of mouth opening will result in difficulty in dental treatment. And in some patients, we have what's called oral blood blisters, where they present with single large bully filled with blood, with subsequent rupture and ulceration, and there will be healing mainly in the area of the soft palate without known cause. It is called erythema multiforme, some associated with the intake of steroid inhalers causing weakening in this area, but it is not clear the pathogenesis. By this, we finished the oral ulcerations. So these are oral ulcerations. Mostly they are traumatic or aphthous ulcers, but you have to know that other diseases, whether they are vesicular loss disorders or systemic disease, they can cause oral ulceration. So you have to be careful. Okay, any question? Any question? No questions? Thank you very much. See you next time.